knowledge, but I think it's important to recognize the types of fecal incontinence. And I think they all affect the patient equally, but it's really important to know what fecal incontinent type of fecal incontinence your patient has. So regarding urge, so discharge of fecal matter occurring with the patient's awareness, against their will because of lack of voluntary control. Post-evacuation fecal incontinence due to the undesired leakage of fecal matter following a bowel movement. And of course, one that's very distressing is passive, where they have the involuntary control, so they're completely unaware that they're actually having an accident. I think because of the stigma associated with fecal incontinence, patients may find it hard to bring it up at their appointment with you. I think of any age, quite often it's failed to be mentioned in the clinician's notes. I find this very often, and if it is mentioned, I have no idea if it's a lot, a little, I don't know how frequent it is, and I think that's really important. You know, I had a patient who I spoke to yesterday who the mother said she's changing the clothes 10 times a day. That can't be normal, and it can't be easy for the parents. I think we've all asked this question, what comes first, behavior causes constipation or vice versa? And I'll be honest, I don't know if we can answer this question, as it's very difficult to derive the initial triggers. By the time we see them, they are so greatly chronic, chronically affected, and symptoms often become worse. And I think it's both ends. So we have been very fortunate to learn how to strategize our testing for children with defecation disorders from our adult colleagues. I'm sure you know some of these names. So the GI physiology unit at the Royal London Hospital, where I originally trained in adults. I was trained from Dr. Mark Scott, who is the expert in lower GI, Professor Daniel Sifram, who's upper GI, and Professor Charlie Knowles. You can see with the Queen. He's the surgeon, the colorectal surgeon in adults, and we do transition clinics with him when the child reaches 16 years old. And they have set up a beautiful service. Obviously the adults are a century ahead of us. They see 1,000 patients a year. They're internationally renowned from the work. And what I like about their service and where I was trained is that they're using scientific evidence to guide management. It's not done by trial and error or maybe this or maybe that. And it's a nice way of dealing with these complex patients. The adult sector has greatly grown regarding the use of anorectal manometry and other investigations, particularly the use of high resolution anorectal manometry, which I'll talk about today. And they recently published a position paper, an international anorectal physiology consensus with the London classification, to basically provide guideline and classification of the technique, but also evolving phenotypes, which I think we have a long way to go for pediatrics. So I'm very fortunate to have them as my neighbours and to look for them for guidance. So in the UK, it's expected practice that adherence to NICE clinical guidelines will be sufficient enough to diagnose and to treat conservatively the patients, the majority of our patients. So obviously conservative treatment, of course, the medication, whether it be laxatives, suppositories, disimpaction, diet, toilet routine, and avoiding withholding. And the area that I struggle with sometimes is the toilet routine, which they don't seem to have. And, you know, I have to say in the UK, they haven't got the most brilliant diet either. So I always say to them, you must use a combination of management plans, not just laxatives. And I always expect the trainees to do some blood tests to rule out the basics, thyroid function test, celiac, transient X-ray, which I'll talk about a bit later on. And of course, if they're suspicious about Hirschman's disease, and after I've done some manometry, we talk about a biopsy if needed. So in the UK, primarily, anorectal manometry testing in children has historically been performed under sedation because of the child's age, the likelihood that they will be uncooperative, or simply because anorectal manometry has been perceived as an invasive procedure. Traditionally, anorectal manometry in an awake child has been largely used in isolated research cases as Hirschman's disease example, or specific conditions, with very limited use of the novel high-resolution manometry. I think performing anorectal manometry under sedation provides limited physiological parameters, as the discrepancy with the type of anesthesia and the level of sedation used that can interfere with physiological outcomes. And as you can see from the table here, you can't really gain much when they're asleep. Of course, we know the rectal inhibitory reflex, which I'll talk about later, and the resting pressure, but you really want to gain a good physiological outcome of your patient. I think in children, we are still appreciating the multifactorial pathophysiological mechanisms involved in these patients and how to direct management and alleviate the distress of the patient's symptoms with clear diagnosis tools and ARM. But as you can see, there's very little in the literature regarding high resolution anorectal manometry. I think there's only 2 or 3 papers who have really looked using this type of resolution. And I think the delayed and to some extent the neglected implementation of anorectal manometry in pediatrics is due to the lack of clear guidance for its use and how this will impact management. So I'm very lucky to be part of the British Society of Pediatric Gastroenterology, Hepatology and Nutrition motility working group. And we spent the last year coming together to create a consensus for anorectal manometry in children identification disorders, which was published in New Gastromotility recently, and there's also a podcast that you can listen to that I did recently with the Mayo Clinic. And I think this kind of gives a guideline as to how and when you should be using this. It doesn't mean it's the right way. It doesn't mean this is the only way. It just gives you some guidance. So this slide demonstrates, I think, the multiple pathophysiological mechanisms that are involved in your patient's symptoms. There are many, as you can see, that could be the culprit to the symptoms of the patient. So I think it's important to appreciate the suprasphincteric dysfunction, the stool consistency and volume, the structural anatomical defects, behavior, compliance, sensation, sphincter, of course, dysfunction, which we've known for years, motility, rectal and colonic sensory function, and of course, we can't forget the psychosocial factors which we need to consider. So, as I mentioned before, CAPS started in August 2016. We were very fortunate to have a team in place, but we needed the funding and the lead clinical scientists to start the service. We got funding from these lovely people here. And as you can see from the slide, we have a fantastic team of people. I'm sure we need to keep on growing, but funding is very difficult. But we accomplished something in 4 years, which is great. So my role, it's a busy one. I conduct all the investigations. I do weekly multidisciplinary team meetings, which are very important every Monday with all my team. I direct and manage the service. I spend a lot of time with a lot of multi-professionals. I do a lot of training in clinical research, a lot of funding applications, which I'm sure most of them fail because it's almost impossible to get funding. I do a lot of guidelines for the UK, lots of teaching from all over, all levels. I spend a lot of time on writing and doing conferences. I do a study and training day every year in the UK, which you're welcome to come to once I have a date planned. And I spend a lot of time fundraising as well. So in the UK, we have received in the last 4 years more than 300 referrals. And because I'm the only service in the UK really that has a routine service, I know that Great Ormond Street and Evelina do a few cases, but we're the only ones who do a weekly routine. And I see, as you can see, I'm not very good with geography, but I see most people around the United Kingdom. So it's a very busy service. So how does it work? We receive a referral, but I don't always accept the referral, to be honest, because I need to make sure I'm not going to cause any unnecessary investigation on the patient. So what I do is I read the referral, present it to my team at the MDT, and based on the referral, I will sometimes say to the referrer, you need to make some changes to your treatment plan and then come back to me. If I suggest that they can go straight to a treatment, I suggest that locally. If they haven't done an investigations, I suggest that. But more interestingly, when I feel like they've done everything and they definitely need some answers, then they come to me to do specialized tests. And it's here that I spend some time speaking to the surgeons, to the health play specialists, and then figure and see which investigations need to be done. So if they come to my service, we discuss the referrals, like I said, what will be needed. Not everyone will have all these tests, but most of them will. And then once I've done the tests, I discuss and present the case every week to my team. So the Children's Anorectal Physiology Service has clear indications, which we have recently published with the FAECAL Motility Working Group, which comprises of various hospitals regarding indication for anorectal manometry and its use. And as you can see on the right-hand side here, these are the indications we believe, based on the group, are clear indications for performing anorectal manometry, whether it be traditional or high resolution. And this is, I think this is very useful. And I think with the functional constipation group, those who are particularly lacking guidance in terms of their symptoms are getting worse, they've tried all the laxatives, and it's been going on for at least a year, and they're going to school and they're still leaking, they're the ones who definitely have to see. So what can we measure with anorectal physiology, or high resolution for that matter? We can measure quite a bit. So we can look at sphincter function, so we can see whether the patient has a normotensive sphincter or hypo or hypotensive sphincter, which we find very useful. I know that people have different views about the enhanced squeeze. I find it very useful. You can have a normal sphincter, but you have the inability to hold on to that squeeze. So by the time you have that feeling to go to the toilet and go there, you don't have the capacity to hold on for very well. And it's a very subjective, you'll see later on when you look at a high resolution. Rectal sensation I find very useful, so the patient can either have normal or be hypo or hyposensitive, which I'll discuss a bit later on. Defecation dynamics, which I find very useful in children, which I also will discuss. And also the reflexes. So we all know the rectal and anal inhibitory reflex, particularly of regarding Hirschman's disease, and the cough reflex to examine the involuntary response to the external anal sphincter. So basically, when I have a patient come and see me, the patients have read the information sheet. I tell them to continue or maximize their laxatives to make sure they're nice and empty, because otherwise it's very hard to measure their anorectum. Some institutes decide to give an enema that morning, but I only do that if only necessary, because I don't want to traumatize the patient. I have the health play specialists with me if they are needed. And I take a very detailed medical history. I spent a long time doing that. And I also do these bowel and psychosocial function scores. And this might take 10 minutes, but it's very useful to gain how severe the incontinence is, how severe the constipation is, their quality of life for the child and family. And of course, if they have any psychiatric morbidity as well, which I find very useful. Most of them would have had a transit study before they come and see me, but sometimes because of the weight, I have to repeat it again just to make sure that I know what the motility is like. So one of the things that I've mentioned before, there's been a lot of issues about anorectal manometry being invasive and causing pain or discomfort. And I remember being in a meeting in Great Ormond Street with a group of people, and I said, why are we not doing this test awake? Why are we doing this asleep? We can get so much information. And I think the main issue was that they needed reassurance that it's not going to be painful and discomfort for the patient. So I did a very simple audit where I asked the patient to tell me after the test how painful it was, and compare it to a blood test, which a lot of children have. And 10 is the worst pain, and here they're very happy, no pain. And as you can see here, the patients report less discomfort with anorectal manometry awake compared to a routine blood test. You can see they've only 3 and 7. So this reassures us and the children and the patient and the parents that this is not painful, avoids the risk of cost and GA, and it's definitely a paradigm shift. We are very fortunate. I'd be interested to know how, what you do in Italy, but we are very fortunate to have a health play specialist. So when I went from adults to pediatrics,